Thank you very much. Thank you, Regina. I have speaker's ADD, which means that I can't hold still when I talk. So I'll be like wandering around a little bit. So if I stand right next to you, it's not because I'm going to like draft you and drag you up on stage or anything like that. Before we get into any of the content, first thing I want to let you know, if any of you were here in the prior session where they were talking about social media, any way you want to get in touch with me, please do so following this. My email addresses, my Twitter handle, my cell phone are up on the slides. They're on all of the slides. I come from a real interesting position in the whole patient empowerment, patient safety perspective. If we imagine the typical paradigm of being, patients on one side and healthcare providers being on the other side, and we're trying to have this conversation across this chasm. I'm not them, and I'm not them. I'm an architect. What the hell is an architect doing in the realm of patient safety? Especially one having to deal with specifically MRI safety. Full disclosure, I have never had an MRI in my life. How does a guy who's never had an MRI, who's not a clinician, who's not, in this case, from the patient perspective, how does this person become involved in MRI safety? In 1997, I designed as an architect my first MRI project. And I fell in love with the technology, what these devices are, what they do. They tickled the geek part of my brain so completely. It was fabulous. And the reason it did so was because I was a young architect. And one of the things that architects are best at is figuring out what they don't need to know to complete a project. If we put the blinders on and we exclude all of the things that are superfluous to this project and we focus in on what does the code say, what do we have to do, how thick do the walls need to be, what are the fire ratings, if we focus on those kinds of things, we can turn out projects very efficiently. And this is what generalists have to do, and I imagine that it's probably pretty similar on the medical side of things from physicians as to what it is for architects. Well, my very first MRI project, it was within a year of getting my master's in architecture. So I didn't know what experienced architects know. So I kind of threw myself into this with a level of involvement and a level of curiosity that's probably not very typical for what architects do. The same hospital, after that project in '97, added another MRI in 2002. In 2002, the summer of 2002, the American College of Radiology published what was then titled the White Paper on MR Safety. And it came out after a horrific MRI accident, and it sort of established best practice procedures for safety in the MRI environment. One of the things that it talked about is controlling access within the MRI suite, how to set up a zone principle that you have to pass through subsequent levels of screening and access controls. The technologist who was running the MRI department at the time read this ACR white paper and said, well, I can't make heads or tails of this. Talks about zones and access controls. You're an architect, you figure it out. And he handed me the paper. And I read through it, and I had the exact same result that he did. I couldn't figure out what on earth this thing meant. So I looked up the list of authors, and Dr. Manuel Canal, who is probably the world's foremost guru on MRI safety issues, is a professor and physician at the University of Pittsburgh Medical Center. He was the main author, the lead author on the paper. So I contacted him, and he graciously kind of walked me through all of this. Through that process, I became really horrified at how little the planning, design, and construction parts of the healthcare world knew about MRI safety, as evidenced by the fact that we designed some of the worst facilities. We collectively designed some of the worst facilities with respect to MRI safety. That was the case in 2002. We're marginally better today. So, say hello to my little friend. As Regina mentioned, she painted this jacket for me, and I have to tell a little bit of the story behind the dialogue between Regina and I creating this jacket. When I asked her if she would be willing to do a jacket for me and she agreed, she said, you know, I really don't know very much about MRI. I'm thrilled to do the jacket for you, but I need some suggestions about subject material, content for this jacket. I said, no problem. I'm an MRI safety guy. I got articles out the wazoo about accidents and injuries and what has happened in MR safety. I'd be happy to share that with you. And I sent, you know, sort of 3 or 4 or 5 of the highest profile kinds of accidents. And she sent me the jacket back. And as soon as I got the FedEx box and it said, from Regina, I tore it open. I was so excited to see what she had picked. And I pull the jacket out and I flip it over and I look at it and I try desperately to figure out, how is this one of the stories that I had sent her the pieces from? And inside the breast pocket is this letter from her. And as I'm scratching my head trying to figure out, well, what is this? Where does this come from? I flip open the letter and I read it. And in it, she essentially said, I started working on some of the story ideas that you had sent me from the news clippings. But some of the accidents in the information, the news clippings that I sent her were so horrific. She said, I didn't want this to be off-putting to people who saw the jacket. And then I realized that I had my own story to tell about MRI safety. And so this jacket is Regina and her husband. And her husband was going in for an MRI. And her husband was nervous about the diagnosis and was somewhat claustrophobic. And so the idea of getting stuffed in an MRI for 30 or 40 minutes was not something he was terribly excited about. And in the letter, Regina describes how she offered to go into the MR exam room and sit and hold her husband's hand while he got the scan. And the technologist, who was very busy and very officious, said, oh, I'm sorry, hospital policy, nobody goes in the magnet room with the patient. And so Regina sat out in the sub-waiting room, and about 30, 40 minutes later, the technologist comes out and is clearly frustrated and says, your husband just will not hold still. He's so nervous, he's squirming all around. And Regina again said, well, why don't you let me go in and hold his hand? Calm him down, he'll hold still, you'll get the scan, and you know, everybody will be happy. So the technologist relented and said, okay, fine, go ahead, you can go in. So Regina goes in, her husband's still inside the MRI scanner, and she leans down at the end of the bore, the opening, the tunnel, and leans down so she can see his face down at the end of the bore and say, honey, I'm here, I'm going to be with you for the rest of the exam. And then what happens? The visitor ID badge that was clipped onto her blouse goes flying off because it had a steel clasp. Whatever screening they did for him, the patient, they never repeated for Regina. And once I heard this story, this was even more perfect than any of the news clippings that I had sent to her. Because those all come from, you know, out there. Happened far away, which is one of the great excuses for why we don't actually need to do anything here, because that accident happened somewhere else. And for Regina, a person with whom my connection is by pure chance, you know, just sort of picking somebody from the United States, one of the 300 million people in this country at random, And she has a story about her own experience in a breakdown in MRI safety. This example is about 100 times more powerful than anything that I would ever see news stories or on CNN. So we see a lot in the news about radiology safety in general. Walt Bogdanich is a New York Times writer, Pulitzer Prize winning New York Times writer. And he has now 8 or 12 articles in the last 2 years about ionizing radiation mishaps, CT scanners that were improperly programmed, or beam therapy systems for cancer treatment that were modified so that they could deliver higher power, and yet somehow the hardware and the software didn't actually work the way they were supposed to together. Patients receiving massive overdoses of ionizing radiation. Well, one of the responses to, well, how do we reduce risks of ionizing cancer-causing radiation from imaging and therapy, how do we reduce the risks to patients? Well, we can just give them more MRIs, because MRI doesn't have ionizing radiation. So we eliminate that risk if MRI is an equivalent, from a diagnostic standpoint, an equivalent imaging option. The problem from that is that we don't really have MRI's house in order from a safety standpoint. No, it doesn't have the cancer risks that you would get from CT or any kind of X-ray based imaging or therapy system, but it does have its own risks. Now, this flies in the face of what we are constantly told about what MRI is, or what the safety profile is and how it presents for patients and clinicians. We are constantly told that MRI is the safe option. We are told that, well, we've got layers upon layers of accreditation and regulation and state licensure. I mean, has anybody ever seen how much regulation there is about radiology? It is tremendous. Unfortunately, none of it applies to MRI, because virtually all regulation that governs safety in radiology is predicated on ionizing radiation. Well, that's what we have to protect against. And it's almost this kind of chicken and the egg kind of situation. Well, because there are no rules that govern the safety for MRI, doesn't that prove that it's safe? Because if it was unsafe, somebody would have written a rule about it. And that's kind of the situation we find ourselves in with MRI. And so people constantly cite the reasons that we have up here on the slide as, you know, MRI is the safe option. We have drunk the Kool-Aid, ladies and gentlemen. We believe that MRI is safer because there are no regulations. We believe it is safer because people say, you know, there's no ionizing radiation, which indeed there isn't. But what we do not believe is that MRI has its own risk factors that need their own distinct responses. There was a tragic accident 10 years ago, 11 years ago now, in which a young boy was killed when somebody walked into the MRI suite with an oxygen cylinder. Happened in Westchester County, New York. The young boy's name was Michael Colombini. He had, a week prior, had a fall on the playground and had hit his head pretty hard, and they rushed him to the hospital and they did a CT scan, and the doctor came out and said, I have good news and bad news. The good news is there's no skull fracture, you don't need to worry about that. Bad news is that the CT scan showed a brain tumor that otherwise, you know, would not have been caught. Because they caught it early, he was able to have brain surgery. After brain surgery, he went in for the MRI scan, and it was in that post-op MRI scan that the oxygen tank got brought into the room, hit him in the head, killed him. And we look at that and we say, well, wait a second, you know, We haven't seen other examples of that accident or one similar to it up on CNN, so clearly, whatever the problem was, we have fixed it. Everything is better. The fact is that there are not a single regulatory, state licensure, or accreditation standard that has been implemented since that accident that would prevent it from recurring. That exact same accident could occur in any ACR accredited, Joint Commission accredited, DNV accredited MRI facility anywhere in the country. Because those accreditation standards don't say anything about physical environment safety in MRI. And the fact is that over the last number of years, MRI accidents have increased alarmingly. If we were to take a look, and we use, for the sake of this argument, we're going to use the year 2000 as a benchmark. We're just going to look at changes that have occurred from the year 2000. This is how many MRI accidents, how MRI accident rates have changed from the year 2000 to the year 2009. 523% increase in the number of MRI accident reports. I gave this presentation to folks at the FDA about a year ago, and the FDA said, baloney. Those got to be made up numbers. Where on earth did you get that data that says there's a 523% increase in accidents? I said, I got it from the FDA. And they said, no way. And they went back and they checked their numbers and they said, oh my God, you're right. How could we not know about this? A lot of people look at the numbers and they go, well, MRI accidents grow. Well, surely they must be in direct response to increases in utilization. We hear all the time about how increasing imaging utilization is driving up costs. Surely it's got to have an accident corollary. In that same time frame, MR utilization grew just slightly less than 90%, which means for every 1% we're adding in growth, we're adding 5+% in accidents over that same time period. Now that little boy in that picture, that's that 6-year-old brain cancer patient who died when the oxygen tank was brought in. That happened in the summer of 2001. In the summer of 2002, the ACR released this white paper on MR safety, this best practice guideline. And what happened immediately after that accident and the papers that showed how to respond to these accidents and these risk factors? All of a sudden, the number of accidents plummets for 2 years in a row. Actually goes below the utilization growth curve in 2004. And then in 2005, 2006, 2007, 2008, 2009, what happens? Well, we got tired of paying attention to all that MRI safety stuff. Not because there weren't additional reminders. The American College of Radiology published 2 additional updates to this, and the Joint Commission published on Valentine's Day 2008 their Sentinel Event Alert number 38 on MRI accidents and injuries. Now, despite the fact that both the ACR and the Joint Commission have published these best practice standards, neither one of them actually require that their accredited facilities do anything that are in their best practice standards. So we know that we can affect positively MRI accidents. We know, we have demonstrated that we can turn this around. Somehow, after 2004, we lost the will to do that. And the accident rates have been climbing alarmingly ever since. This, by the way, is how much regulatory and accreditation changes there have been relative to MR safety in that same time frame. 0. So we collectively, as a community, as a country, have simply watched the number of people who we are needlessly injuring go up and up and up and up and up and have done nothing about it. And if today's situation makes us nervous, we should be particularly worried about tomorrow's situation. Because all of the risk factors for MRI accidents and injuries are climbing. Aging population. As we get older, we need MR imaging, or we utilize MR imaging dramatically more than when we're younger. As we get older, we're more likely to have clinical contraindications for MRI exams. Not only are the patients changing, but the clinical applications. We are using MRI for emergent and trauma cases, more so today than at any point in the past, and that growth is expected to climb dramatically. So we're taking patients who are in more acute conditions, and we're putting them in MRI scanners to do these exams. The MRI scanners themselves are changing. They are getting more and more powerful. Stronger magnetic fields, stronger RF fields. This is all technical mumbo jumbo, but what that translates into ultimately for patients is increased risks for projectiles, for burn types of events. And then while all of these risk factors are changing under our feet, the rate of reimbursement for performing the MRI exam has taken a nosedive. Now, if a hospital or an imaging center has a fixed cost of the MRI scanner, and believe me, GE, Siemens, Philips, they're not reducing the cost of their MRI scanners simply because your reimbursement rates are declining. So if your fixed costs are the same and your reimbursements are going down, the only thing left to touch are your variable costs, staffing. So we reduce either the number or the quality or both of the people charged with running the MRI scanners themselves. Now, just to take a quick look graphically at what this means for the aging population. The front edge, the leading edge of the baby boomers are hitting 65 right now. And so if we did nothing else in the industry and we just look at the changes that are going to be driven by demographics, we're in for some really remarkable changes in demographics and the risks that they translate directly. With my friend and colleague, Dr. Canal, we looked at 2 years of FDA MRI accident reports, and we found that 92% of them were essentially user error, pilot error, accidents that occurred at the point of care. And nearly all of these were preventable through existing best practice standards that nobody requires. And I want to compare and contrast the bulk of MRI accidents, these sort of procedural or operational, with a condition that's called nephrogenic systemic fibrosis, abbreviated NSF. 7 years ago, you could count on your fingers the number of people in the entire world who knew what nephrogenic systemic fibrosis was. It was a disease that today, the total number of confirmed cases is somewhere less than 500 globally for all time. When NSF was really sort of came to light in late 2005, late 2006, early 2007, there was a global coordinated effort to identify the cause of this disease, which turned out to be related to MRI contrast agents, how to screen for risk factors, how to change the way we deliver contrast dose in MRI so that we could eliminate this disease. The number one problem with research in NSF today is we have no new patients. We can't research the disease because nobody has it, or nobody new is getting it. This is for a disease with a total number of affected people of less than 500. We estimate that there are about 7,400 annual cases in the US alone of accidents and injuries related to operational policies and procedures in the MRI environment. If we can coordinate a global effort in response to a disease that affects 500 people. And I'm not disparaging that effort. I am pleased and proud beyond measure that we can devote those kind of resources to the problem of NSF. But if we can do that, how is it that problems that we know the responses to, how is it that we can't do that for the things that are affecting the greatest number or injuring the greatest number of patients in the MRI environment? So people ask me as an architect, why do you do this? Why are you involved in this? You are an outsider. You can't possibly affect the change. Hello. This is a picture of my mom. And my mom taught me something that has taken on a new meaning. She worked at a university. And universities are probably similar to healthcare in that they're big bureaucracies and very difficult to kind of shift, try and get them to move and do something different. And she taught me, when I asked her, why do you keep trying to do these things that people tell you you cannot do? And she said, the reason is because I care about this. And I see my job as nudging the system. The people who object to the things I want to do don't object because they don't like the things I want to do. They object because it means change, or it means, increased budget, or it means collateral things that they don't want to have to deal with. They don't object to what my issue is. But I care about my issue. And so while they may object about budget today, I'll be asking about it next year when we discover we have a slight budget surplus, is why they can't do that. And then they won't have that objection. The thing that we all have, that we share, is tenacity. We can be the nudgers, because whatever issues are important to you, to me, are ones that we care about and we are not letting go of. And so all of the people who get in our way and say, you can't do this, you can't affect this change, to them I say, well, maybe not today I can't, but I'm going to be here tomorrow, and I'm going to be here next month, and I'm going to be here next year, and I'm going to be here 10 years from now, and I'm willing to bet that you're not. You're not going to be standing on the other side of me. So my parting message is, by doing this, by being committed, by being willing to be here and take the steps that you take, you will affect change. I will affect change. It has already happened and will continue to do so. So that is why this as a community is so tremendously important. I will have these slides, which will, if you are more interested in the MRI safety details, which I didn't get enough chance to talk about in detail because I wanted to talk more about sort of the reason that this is important to me. I will make these slides available, and I'll coordinate with Regina, and we'll figure out a way for you to get them, and you'll see several of these. So thank you all very much. Thank you.